The DSM-5, a taxonomy of human suffering and the architecture of mental illness. Let us begin with a document that wields more power over the human psyche than perhaps any other in the modern Western world. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, known with that characteristic American fondness for acronyms as the DSM-5. This tome, published by the American Psychiatric Association in 2013, after more than a decade of deliberation, is not merely a book. It is the operational canon of mental illness, the Rosetta Stone by which clinicians, researchers, insurance companies, and courts encode human suffering into actionable categories. It determines whether your anguish qualifies for treatment, whether your disability is recognized, whether your suffering has a name that institutions will honor. The DSM-5 presents itself as the product of scientific consensus, an evolving document that reflects our best current understanding of mental illness, continuously refined as evidence accumulates. And in large measure, that is precisely what it is. The mechanics of creation, how a diagnostic manual is built. The DSM-5 was assembled over the course of approximately 14 years, from 1999 to 2013, by a substantial community of psychiatrists, psychologists, and other mental health professionals. The American Psychiatric Association appointed a task force and multiple work groups comprising roughly of 160 members in total, organized into 13 diagnostic categories. They were not casual gatherings. The work groups met repeatedly in person via conference calls and email exchanges at various locations, frequently including the APA headquarters in Arlington, Virginia. The members were drawn predominantly from American academic psychiatry. Nevertheless, there was a meaningful international representation to reflect the global nature of psychiatric practice. Each work group was charged with reviewing the scientific literature pertaining to their assigned category of disorders: mood disorders, anxiety disorders, psychotic disorders, and so on. They examined epidemiological data, neurobiological research, treatment outcome studies, and field trials conducted specifically to test proposed diagnostic criteria in real clinical populations. The decision-making process worked as follows. Work groups would propose changes, modifications to diagnostic criteria, addition of new disorders, elimination of emerging or old ones, based on their systematic review of the literature. These proposals would then go to the task force for review, then to a scientific review committee, then to a clinical and public health committee, and finally to the APA Board of Trustees for approval. It is a substantial bureaucratic apparatus designed to ensure that multiple layers of scrutiny are applied before any change reaches the final published manual. Field trials were conducted at multiple sites to test the reliability of proposed new diagnoses. Whether different clinicians examining the same patient would arrive at the same diagnosis. This kind of inter-rater reliability testing is fundamental to scientific validity. The shadow of financial interests. That said, the process has not been without legitimate criticism. 69% of the DSM-5 task force members reported financial ties to the pharmaceutical industry, according to a 2012 analysis published in Psychotherapy and Psychosomatics. For some panels, particularly those dealing with mood disorders and psychotic disorders, the percentage was even higher. The APA has implemented conflict of interest policies requiring disclosure of financial relationships, and members with significant conflicts were restricted in their roles. Whether these safeguards are sufficient is a matter of ongoing debate within the profession itself, a debate that serious psychiatrists engage with openly and honestly. The concern is not necessarily one of direct corruption, but a more subtle form of influence. Pharmaceutical companies fund research, sponsor conferences, support continuing medical education, and provide consulting fees to leading experts. These relationships can shape what questions get asked, what outcomes get measured, and what threshold gets drawn without any individual acting in bad faith. The curious case of restless legs syndrome illustrates this concern vividly. RLS became a formal diagnosis with detailed criteria and treatment guidelines at roughly the same time as GlaxoSmithKline was seeking FDA approval for Requip or ropinirole to treat it. A massive direct-to-consumer advertising campaign followed, and suddenly millions of Americans discovered that they had been suffering of RLS without knowing it. Requip became a blockbuster. Was RLS invented for Requip? That is perhaps too crude of a formulation. The symptoms are real, and the suffering of those who experience them is genuine, but the timing of diagnostic codification, the funding of awareness campaign, the support of patients' advocacy groups, and the dissemination of medical education materials all coincided with the commercial interests of a pharmaceutical company in a manner that warrants scrutiny. It raises the legitimate question: to what extent is psychiatric diagnosis shaped by therapeutic availability rather than by independent observation of natural disease entities? This is not a fringe concern. It is one that responsible members of the psychiatric community themselves raise, and is one that should inform how we read and apply the DSM-5. The power of taxonomy, why this matters. Why should we care about the deliberation of a committee of psychiatrists producing a diagnostic manual? Because DSM-5 is not merely descriptive, it is constitutive. It does not simply catalog mental illness that exists independently in nature, it creates the categories by which mental suffering is understood, researched, treated, and compensated. The ancient Egyptians understood something profound about the power of naming that resonates across millennia. To protect themselves, many Egyptians actually maintained two names: the small name, Ren Neges, the public name that everyone knew, that friends used, that was carved on monuments, and the true name, Ren A, or the big name, the secret name, often given at birth by the mother and kept strictly hidden. The secret name, they believed, stated the true nature of a person's soul. To know someone's true name was to own them. If a magician or an enemy knew your secret name, they could cast spells that would affect you directly, bypass your spiritual defenses, or even destroy your soul in the afterlife. By keeping the name secret, you essentially kept your master password safe, protected from those who would use that knowledge against you. The DSM-5 operates on a structural similar principle. Once you've received a psychiatric diagnosis, that name acquires institutional power over your life. It appears in medical records, insurance files, disability determinations. It becomes, in a very real sense, your psychiatric true name, and those who possess it acquire influence over fundamental aspects of your existence. Consider the implications for research. When a researcher wants to study depression, they use the DSM-5 criteria to define which patients have depression and which don't. All subsequent research is therefore shaped by how the DSM-5 drew those boundaries. The DSM-5 doesn't just describe depression, it determines what depression is for research purposes and thus determined what treatments will be developed and for whom. For insurance companies use DSM-5 diagnosis to determine what they will reimburse. No DSM-5 diagnosis means no reimbursement. The manual, therefore, determines whether suffering is institutionally legitimate or not. Your anguish must fit into one of its categories, or the financial architecture of healthcare will not support your treatment. For disability, Social Security disability determinations, educational accommodations, workplace protection, all rely on DSM-5 diagnosis. The manual determines not just who gets treatment, but who gets benefits, accommodations, and legal protections. For criminal justice, legal questions of competency, criminal responsibility, and risk assessment all involve DSM-5 categories. The manual helps determine who goes to prison, who goes to a psychiatric facility, and in capital cases, whose life may be spared on grounds of mental illness. For pharmaceutical development, drug companies design clinical trials around DSM diagnosis. The FDA approves medication for DSM diagnosis. The entire apparatus of psychopharmacology is built upon the DSM taxonomic foundation. The Egyptians kept their true names secret to protect their souls from those who would use that knowledge to harm. The DSM assigns psychiatric names through clinical encounter and shares them across institutions with power over our lives. The ancient magicians could only affect those whose true names they possessed. Modern institutions, insurance companies, employers, courts, disability boards can only engage with those whose DSM names have been formally assigned. The power of naming has not diminished over 3 millennia. It has only changed its form and its agents. The structure: 20 categories of human suffering. The DSM-5 is organized into 20 major diagnostic categories, having abandoned the multi-axial system used in DSM-4 in favor of a more integrated approach. Let me describe this structure. Neurodevelopmental disorders. For example, autistic spectrum disorder, ADHD, intellectual disability, specific learning disorders, conditions with onset in the developmental period, many of which persist across the lifespan. Schizophrenia, spectrum, and other psychotic disorders. Examples: schizophrenia, schizoaffective disorder, delusional disorder, brief psychotic disorder. The serious thought disorders characterized by delusions, hallucinations, and disorganization of thinking. Bipolar and related disorders, for example, bipolar 1, bipolar 2, cyclotimic disorder. It's separate from depressive disorder and DSM-5, reflecting their distinct neurobiology and treatment requirements. Depressive disorders. Examples: major depressive disorder, persistent depressive disorder, formerly called dysthymia, premenstrual dysphoric syndrome, the spectrum of depressive conditions from episodic to chronic. Anxiety disorders. Examples: generalized anxiety disorder, panic disorder, social anxiety disorder, specific phobias. That is the pathological fear and worry that impairs functioning. Obsessive compulsive and related disorders, for example, OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, separated from anxiety disorder in DSM-5 to reflect shared phenomenology and neurobiology. Trauma and stress-related disorders, for example, PTSD, acute stress disorder, adjustment disorders, conditions causally linked to exposure to traumatic or stressful events. Dissociative disorders, For example, dissociative identity disorder, dissociative amnesia, depersonalization, derealization disorder, disruption in the normally integrated function of the consciousness, memory, identity, and perception, somatic symptoms and related disorders. For example, somatic symptom disorder, illness anxiety disorder, the former hypochondriasis, conversion disorder, condition where physical symptoms are prominent and associated with significant psychological distress. Feeding and eating disorders. Example, anorexia nervosa, bulimia nervosa, binge eating disorder, persistent disturbances in eating behavior with significant health consequences. Elimination disorders. Example, enuresis, encopresis, conditions involving inappropriate elimination of urine and feces beyond the developmental age at which control is expected. Sleep-wake disorders. Example, insomnia disorders, narcolepsy, restless legs syndrome, disorders of the sleep-wake cycle that cause significant distress or functional impairment. Sexual dysfunctions, for example, erectile disorder, female sexual interest or arousal disorder, premature ejaculation, clinically significant disturbances in sexual response or experience. Gender dysphoria, significant distress associated with incongruence between experienced gender and assigned gender. Disruptive impulse control and conduct disorder. Examples, oppositional defiant disorder, intermittent explosive disorder, kleptomania, pyromania. Conditions are characterized by problems with self-regulation of emotions and behavior. Substance-related and addictive disorders. Examples are alcohol use disorder, opioid use disorder, gambling disorder. Notably, DSM-5 introduced the gambling disorder as the first non-substance behavioral addiction. Neurocognitive disorders, for example, delirium, major and mild neurocognitive disorders, Alzheimer's disease. These are conditions involving acquired deficits in cognitive function. Personality disorders, examples, borderline, narcissistic, antisocial, avoidant personality disorders, enduring patterns of inner experience and behavior that deviate markedly from cultural expectations and cause significant distress or functional impairment. Paraphilic disorders, examples, voyeuristic disorder, exhibitionistic disorder, pedophilic disorder. DSM-5 distinguishes between paraphilias, atypical sexual interest, and paraphilic disorders, which cause distress or involve harm to others. Finally, other mental disorders, a residual category for presentations that do not meet full criteria for any specific disorder but cause clinically significant distress or impairment. Other conditions and the Z codes. The DSM-5 includes an important category called other conditions that may be the focus of clinical attention, previous known as V code. These have been updated to Z codes to harmonize with the ICD-10 coding system, reflecting the increasing internationalization of psychiatric and medical classifications. The Z codes are not mental disorders per se, but circumstances and problems that many nonetheless require clinical attention and treatment. For example, relationship problems, parent-child conflict, partner violence, sibling relational problems, abuse and neglect, physical, sexual, psychological, educational and occupational problems, housing and economic problems, problems related to the social environment, and so on. Z codes represent an important acknowledgement within the DSM-5 that mental health and well-being are not purely products of individual neurobiology. Social circumstances, relational, environmental, economic conditions, and traumatic experiences shape psychological health profoundly. A clinician working with someone in an abusive relationship or experiencing homelessness or navigating a devastating legal situation may need to document these circumstances, even if they don't rise to the level of a formal mental disorder. The antechamber, Section 3, and conditions for further study. The truly fascinating intellectual territory resides in Section 3 of the DSM-5, under a chapter entitled Conditions for Further Study. This is the antechamber where proposed disorders await sufficient evidence for formal inclusion, or in some cases where they will quietly fade away as evidence fails to materialize. Section 3 represents the living edge of psychiatric taxonomy, where clinical observation, emerging research, and theoretical frameworks intersect. These are conditions that show sufficient promise to warrant systematic study, but for which the evidence base is not yet robust enough to justify full diagnostic status. What resides in this antechamber? Attenuated psychosis syndrome, characterized by psychotic-like symptoms that are less severe and more transient than full psychosis, occurring in individuals who remain in contact with reality. The clinical goal is early identification of individuals at heightened risk for developing schizophrenia, allowing for early intervention. Depressive episodes with short duration, hypomania, presentations that resemble bipolar II disorders, but where hypomanic episodes are shorter than the 4-day minimum currently required. Research suggests this may represent a genuine clinical entity with distinct treatment implications. Persistent complex bereavement behavior. Grief responses that remain severely debilitating beyond what is culturally expected, characterized by persistent yearning, difficulty accepting the loss, and significant functional impairment. The challenge here lies in distinguishing pathological grief from the profound but ultimately adaptive mourning that follows devastating loss. Caffeine use disorder, problematic patterns of caffeine consumption associated with clinical significant impairment. The evidence base is modest, and this remains appropriately in the antechamber. Internet gaming disorder, persistent and recurrent engagement in gaming that results in significant impairment, with emerging neurobiological evidence suggesting parallels with other addictive disorders. Suicidal behavior disorder, and non-suicidal self-injury disorder, both representing an important conceptual shift towards recognizing that these behaviors may warrant clinical attention as entities in themselves independent of the diagnosis with which they are frequently associated. Section 3 is intellectually honest in a way that is often underappreciated. It publicly acknowledges the boundaries of current knowledge, invites systematic research, and resists premature closure on questions that remain genuinely open. Today's Section 3 conditions may become tomorrow's established diagnosis as evidence accumulates, or may quietly retire as research fails to support its validity. New trends towards more objective foundations. There is a growing and serious effort within psychiatry to move towards more objective, biologically grounded diagnostic foundations, an effort that both reflects and drives important changes in how mental illness is understood and researched. Research Domain Criteria, or RDOC, developed by National Institute of Mental Health, represents perhaps the most ambitious of these initiatives. RDOC attempts to classify mental conditions based on dimensions of observable behavior and neurobiological measures, neural circuits, genetics, physiology, behavior, and self-report, rather than purely on symptom clusters. It's an effort to ground psychiatric classification in neuroscience without waiting for that science to be complete. Biomarker research seeks objective, measurable indicators of mental illness, brain imaging patterns, genetic markers, inflammatory markers, neurochemical signatures. The aspiration is that future diagnostic systems might incorporate biological measures alongside clinical observations. Similar, like cardiology uses EKG findings alongside symptoms, or oncology uses biopsy results alongside clinical presentation. Dimensional approaches challenge the categorical yes-no structure of current diagnosis, proposing instead that mental conditions exist on a continuum of severity. Rather than having or not having depression, a patient might be rated on multiple dimensions: mood, cognition, neurovegetative symptoms, functional impairment, allowing for a more nuanced clinical characterization. Network approaches conceptualize mental disorders not as a discrete disease entire with single underlying causes, but a network of interacting symptoms where certain symptoms activate or maintain others. This framework may better explain the heterogeneity observed within diagnostic criteria and may point towards a more targeted intervention. The development represents genuine scientific progress, the field genuinely wrestling with the limitations of its current tools and investing seriously in better ones. The fundamental question, which brings us to the question that underlie all of this: are mental illnesses discovered or invented? This is a question that haunted even prototypical objective sciences like mathematics. Plato believed that mathematics exists in some kind of higher level of existence, and it is just discovered by people. Others are saying mathematics is invented by people to help explain and predict the laws of nature. The famous example is the invention of calculus by Newton or Leibniz, meant to resolve irregular realities. When it comes to psychiatry, the answer almost certainly is both, and in proportions that vary by condition. Some mental disorders, schizophrenia, bipolar disorder, autistic spectrum disorder, the dementias, appear to represent genuine neurobiological entities, even if we don't yet fully understand their mechanisms. The evidence for their validity as distinct diseases is substantial, even if our ability to define them with biological precision remains incomplete. Others, many of anxiety disorders, some of the depressive disorder, the personality disorders, occupy territory where the boundary between pathology and the extreme range of normal human variation is genuinely uncertain. This does not make the suffering less real or the need for clinical attention less urgent, but it does mean that the diagnostic criteria themselves carry greater uncertainty, and the threshold drawn are partially clinically and scientifically judgments and partly cultural and institutional ones. What is undeniable is that DSM-5 wields enormous power. It shapes research, determines insurance coverage, governs disability decisions, influences criminal proceedings, and structures the entire enterprise of psychopharmacology. It determines which suffering is institutionally recognized and which is not. The process, which is created by expert committee reviewing evidence, deliberating carefully, and making judgments under uncertainty, is the best process we have so far. The financial relationship between the psychiatric profession and the pharmaceutical industry warrant ongoing scrutiny and robust conflict of interest management. The question of where diagnostic thresholds should be drawn remains genuinely contested. The challenge of distinguishing disorder from variations that are normal remain incompletely resolved. The DSM-5 is not the final word of human suffering. It is the current best word, provisional, evolving, and appropriately subject to revision as knowledge advances. Understanding both its power and its limitations are essential for anyone who uses it, is affected by it, or simply wants to understand how modern medicine navigates the ancient mystery of the troubled mind.